right, everyone, it's 12 o'clock. We're going to go ahead and get started. This is the provider to provider I'm sorry, I'm going to start over. Hi, everybody. This is the provider to provider pediatric mental health tele-echo series. And today our topic is ADHD in pediatrics. I am Jody West. I want to welcome everybody to the session. This is the agenda for today. We're going to work do our best to stick to the time. As you know, if you participate before, it goes by pretty quickly. We're going to start with brief introductions, and then we'll have a didactic presentation from Dr. LaRose on ADHD in pediatrics. And Dr. Cocky is going to present a case. We'll have time for clarifying questions and recommendations, which will be sent out to everyone. And then we'll have a wrap up with announcements for the next session. So on to introductions. Like I said, I'm Jody West. I am the coordinator for the ECHO, but also the program manager for the provider to provider consultation line. We provide mental health consultation across the state for providers working with patients and clients that have mental health concerns and needs. You can contact us to discuss cases. You can have access to psychiatrists that we have on our team to discuss medications and diagnosis if needed. If you need help finding resources in your community, we can assist with that. In pediatrics is 0 to 21. We also provide consultation for the perinatal period, which is pregnancy and up to a year postpartum. So if you scan this code, it brings you to our website, and that'll allow you to get updates from us, educational opportunities like today's ECHO, and also a newsletter that we send out monthly with other updates. So I'm going to hand it over to Dr. Olivier, who is going to facilitate the rest of the presentation today.
All right, thank you, Jody. Good morning, everybody, or good afternoon, everybody. I always make that mistake. I'm Dr. Olivier. I'm a child and adolescent psychiatrist here in Lafayette, Louisiana. I work at private practice at Bloom Mental Wellness. I am the facilitator for these sessions, so I try to keep us on time and kind of give you a heads up of what's coming. I'm going to go ahead and ask the rest of the hub team to reintroduce themselves. Jody introduced herself as the program director, coordinator already. How about Ashley Hutchins?
Hi, my name is Ashley Hutchins. I'm a psychiatric nurse practitioner, and I work in Lafayette, Louisiana at Bloom Mental Wellness as well.
Thanks, Ashley. And Dr. Cocky.
Hello, everyone. I'm a general pediatrician in Broussard, Louisiana. We have to have a pediatrician on our little hub team, so thanks for attending.
Thank you for being part of the hub team, Dr. Cocky. So you see, we have a pediatrician, we have a child adolescent psychiatrist, we have a psych NP, and then we also have a couple of social workers. Jody West is being one of those, and Lena. You want to introduce yourself?
Sure. Hi, everybody. My name's Lena Riggett. I'm one of the social workers and mental health consultants for PPCL. And so I'll just help facilitate discussion today, ask questions, provide recommendations, and also doing a lot of IT behind the scenes work for everyone here on the ECHO.
Thank you, Lena. And thank you, everybody, for joining us again. I'm going to turn it over right now to Dr. LaRose, who is presenting today on ADHD. So thank you for volunteering, Dr. LaRose, and you can go ahead and take it away.
Okay, great. Okay, so ADHD is kind of our bread and butter in child psychiatry. And I know a lot of the primary care providers see this a lot as well. So I think it's very relevant for all of us. So should I just tell you when it's time to change the slide?
Yes, just give me a verbal cue, Dr. LaRose.
Okay, you can go ahead and switch. Okay, so I'm not going to spend a whole lot of time on the DSM-5 criteria because we can all look it up, but just kind of go over the basics. Okay, so symptoms of ADHD have to be present for at least 6 months and at least in 2 settings. So for kids, we're mostly looking at school, home, sports, and then there's a few other activities that can be telling, like times when they have to sit still, like in church or at a movie theater, okay, or at the dinner table. Symptoms have to be negatively impacting their functioning in some way, all right? And then as far as age criteria, in patients under 17, at least 6 symptoms need to be documented. And then for 17 and older, it needs to be at least 5 symptoms. You can go to the next slide. Okay, so inattentive symptoms, trouble listening when spoken to directly, losing things a lot or misplacing things, very easily distracted, forgetful, trouble sustaining attention for long periods of time. This is going to change depending on their age because the attention span of a 5-year-old is different than the attention span of a 17-year-old, or should be. Inability to complete tasks, avoiding or procrastinating work, trouble focusing will lead to like a lot of careless mistakes or thoughtless mistakes in their work. All right, next. And then hyperactive symptoms. These can be a little bit easier to diagnose because you can see it with your own eyes. So very squirmy, fidgety, very restless, feels like they're always like go, 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 always on the run, trouble relaxing and winding down, trouble staying seated or sitting still, and then talking excessively. That also includes like blurting out, interrupting. All right, next. Okay, and then impulsive symptoms, which we really often diagnose the hyperactive and impulsive symptoms together, but trouble waiting for their turn, again, interrupting, blurting out, intruding into conversations. All right, next. Okay, so there's been a lot of back and forth about like the age of onset, but right now what we're saying is that symptoms have to be present before the age of 12. And they cannot be better explained by some other psychiatric disorder, can occur exclusively within a psychosis. And it cannot be exclusively a manifestation of oppositional behavior, because then we would be looking more at like oppositional defiant disorder. All right, next. Okay, so we classify ADHD into different types. So kids who are combined type meet criteria for both inattention and hyperactive impulsive criteria for the past 6 months. And then we have the predominantly inattentive kids who are meeting the inattentive criteria but not meeting criteria for hyperactive impulsive. And then the opposite. We have the hyperactive impulsive type. They're not meeting criteria for inattentive type. And then it can be classified as mild, moderate, or severe based on symptom severity. Next. Okay. This I find is like really confusing for a lot of parents and other professionals that, you know, we hear the word evaluation and that can mean a lot of different things. So a psychiatric evaluation, or like what we would call a psychiatric intake or a complete psychiatric evaluation, is done either by a psychiatrist, an MD, or a psychiatric nurse practitioner. That includes what we call a complete psychiatric review of systems. So we are also evaluating for a whole host of other mental health issues, like different types of anxiety, mood disorders, behavior disorders, etc., psychosis. It also includes a complete history, medical history, family history, social, educational history, substance use, and the parents or caregivers are involved in that intake process. So we're getting a history from them. A psychological evaluation, which is also what people call testing, like ADHD testing. Okay, so this is done by a psychologist, a PhD. So that is someone who went to a PhD program for psychology. That was their graduate school. This includes IQ testing, screening for other psychiatric disorders, like anxiety, depression, behavioral issues, and should include some actual test of their attention, memory, impulsivity. Okay, one example that some people have probably heard of is CPT testing, and it's basically a little computer test that tests like how well they're paying attention, how impulsive they are, how inattentive or distracted they are. And then a psychoeducational evaluation is the psychological testing, like I just discussed, plus what we call educational testing. And that is used to rule out learning disabilities, like dyslexia or a math learning disability. So a psychological evaluation does not always include the educational piece. So it's not always evaluating for learning disabilities. Okay, you can go to the next slide. Okay, some screens and scales that can be used to help providers to narrow down a diagnosis of ADHD. One really common one is the child behavior checklist. And this is done by the parent to assess for different emotional behavioral issues. I really like the Vanderbilt and the Connors because, well, really specifically the Vanderbilt. The Vanderbilt has a component that's done by the parent caregiver and one that's done by the teacher. So we're getting a view into two different settings for the kid. I also like it because it rules out some other conditions that can look like ADHD, such as oppositional defiant disorder, conduct disorder, and then anxiety and mood disorders. And then the Connors is done by parent, teacher, and caregiver for younger kids, but older teens can complete it on their own. All right, you can go to the next one. Okay, so other things to consider, because I think a lot of providers, especially in the South, we kind of jump to a diagnosis of ADHD without ruling out other potential things that could be causing these symptoms. Something that I actually do end up seeing a lot is vision and hearing issues. That tends to be in younger kids. Older kids, I find, have been screened enough times that these things are going to be caught. But a lot of times in the younger kids, there is like a vision or hearing issue that's making them look inattentive. So this is mostly for like inattentive ADHD. Sometimes though, we'll see kids really young, like preschool age kids, where they have a lot of behavioral problems. And we find out that part of the issue is just that they can't focus, aren't learning, and then they're acting out, basically. There are some medical issues that can also present with ADHD type symptoms. I had a kid who ended up having absence seizures and just had looked really inattentive. And, you know, those can be hard to catch. Post-concussive syndrome. So, you know, a lot of kids have a concussion at some point. Maybe the parents know, maybe they don't. And the kid is just like very inattentive and distracted afterwards. Anemia. I've been seeing that. I tend to see that. I mean, a lot of my teenage girl patients, but sometimes younger too, where they're just like really tired and unfocused. And then PANS and PANDAS. So one of the chief symptoms in that condition is ADHD type symptoms. Something that I really harp on, this is just kind of my passion, is screen time. And not to say that screen time necessarily causes ADHD, but it definitely can cause some symptoms of ADHD, and it can make pre-existing ADHD a lot worse. So the type of screen time is almost more important than the quantity of screen time. So if kids are using a portable electronic device like an iPad or a cell phone, that is actually much more damaging for their attention span than just traditional TV. So the type is very important. So 2 hours on an iPad is not the same as 2 hours on watching TV in terms of what it does to their attention span. So talking with parents about like, what does screen time look like in the house? What kinds of screens do kids have? How much are they using it? When are they using it? Versus like, how much time are they spending doing any other things that kids do, like playing outside? All right, next. Diet can make a big difference too. So how much sugar are they getting? Are they getting access to caffeine, processed foods, food dyes, etc.? Is there some kind of nutritional deficiency because they're not eating a healthy, well-balanced diet? And then if it seems that the kid's symptoms are only happening in one setting, it's really important to dive in and figure out what's going on, because we know that ADHD is not just going to present in one setting. So if it's only happening at home, we have to figure out what else is going on at home. Is there abuse, neglect? Are there family relational issues? Has there been a big change in the family, like a divorce or a new baby or moving or a death? If it's only happening in school, then we really need to think about whether or not there's a learning disability. And then I've actually had a few, interestingly, that only happened in sports, and then they did end up having some like kind of coordination issue where they just were like had kind of zoned out and stopped participating. All right, you can go to the next one. And just like kind of to, I recognize that like a lot of doctors only have about 5, 10, maybe 15 minutes with parents. So these are all things that happen like over a long period of time. Like you most likely are not going to get all this information day one. A lot of times, in my job, like I'm kind of intervening in a crisis with ADHD, like just trying to get a kid through the school year, get them not kicked out of school or failing out of school. And then like over time, we're peeling back the layers of the onion to figure out like, is there something else going on, or how else can I support this kid besides prescribing the medication? Okay, so treatment options. Accommodations, those can be in the school setting and at home. Those in school, we're looking at things like extended time, distraction-free environment for tests, preferential seating, so allowing them to sit in the front of the room closer to the teacher, or in the back of the room so they can stand up and wiggle and are not distracting other kids. Some schools are more accommodating than others. So some schools, the list of accommodation goes on and on and on. It just depends on what type of school the kid is in. ADHD coaching mostly helps with inattentive symptoms. So like organization, time management, prioritizing tasks. It's not going to be very effective for hyperactive impulsive symptoms. Supplements, we have the most evidence for omega-3 fatty acids, zinc, magnesium, and B complex vitamins. I usually tell my patients, like, we're probably not getting enough of that in our diet anyway, so it's not going to hurt to add those in for the most part. And then any dietary changes that can be reasonably made by the family, like limiting sugars as much as possible, cutting out certain dyes, processed foods, just ramping up, the healthy foods, fruits, vegetables, proteins. All right, next. Okay, and then going back to the screens, like figuring out how can the family limit total screen time as much as possible, maybe change when they can from like a portable electronic device just to TV. And, just knowing that kids with ADHD are at the highest risk for excessive screen time based on all the research that we have. And unfortunately, they suffer the greatest consequences of excessive screen time as well in terms of their cognitive and executive functioning. Sleep is super, super important. So just like focusing on healthy sleep habits, sleep hygiene, making sure kids are getting enough quantity and quality of sleep, and then increasing time outside as much as possible, them being physically active. And then last but not least, medications. You can go to the next one. Okay, so stimulants, if you're going to prescribe a stimulant, there's 2 types of stimulants. There's methylphenidates and amphetamines. Methylphenidates should technically be the first line for children because they are lower potency. There's different types, like under that general umbrella, we have just pure methylphenidates. That's things like Concerta, Ritalin, Cotempla, Quilitree, Quilivant. And then we have dexmethylphenidates. So that's like Focalin or Asteris. The delivery method can be a big deal for kids. So fortunately with methylphenidates, we have endless options. There's liquids, tablets, capsules, disintegrating tablets, chewables, patches, all kinds of options. Length of action is very important. So there's short acting or immediate release stimulants, and then there's extended release or long acting stimulants. I would say most of my kids that are school age are on an extended release, but on occasion there's a kid that, their appetite is so restricted that they're losing weight, they're not growing. So then we might need to switch to immediate release so that it's dosing around meals and allowing them to eat a good lunch at school. All right, next. Okay, so amphetamines, since they're more potent, are going to be used more often in older teens and young adults, like for our pediatric patients, and then obviously older adults as well. There are a few different types. So there's pure amphetamines, there's pure dextroamphetamine, and then there's the combo dextroamphetamine, amphetamine, and then we have lisdexamphetamine, otherwise known as Vyvanse. Again, delivery method can make a big difference. There's fewer options in the amphetamine group, but there's a few. And then also length of action, immediate release versus extended release stimulants. Right, next. Okay, non-stimulants. I have been trying to use non-stimulants more and more when I can. We have a really, really high rate of stimulant prescriptions in Louisiana. And so I've been trying not to contribute to that when I can. So there's basically two general groups of non-stimulants. There's what we call alpha agonists, guanfacine and clonidine. These are the lowest potency option of all the ADHD medications, which can be a good thing and a bad thing. So efficacy is lower. But also risk of side effects for the most part tends to be lower, and there tends to be fewer side effects. These are usually dosed at night because they kind of make kids sleepy. I find that they're much more targeted for hyperactivity, impulsivity compared to inattentive symptoms. Not that they don't work for inattentive symptoms, but just not going to be as strong for those. And then there are immediate release and extended release versions. For the most part, if you're trying to control ADHD with a alpha agonist, you're going to want to use an extended release so that it's actually working during the day. But for some kids, they just are so groggy and oversedated in the morning, they just like can't handle the extended release. All right, next. And then we have what we call our norepinephrine reuptake inhibitors. So atomoxetine or Strattera is the one that's been around longer. And then Qelbree is newer to us in the US, but has been used in Europe for a long time for depression. These are both capsules. Qelbree can be opened and sprinkled, but atomoxetine cannot. So atomoxetine has to be swallowed whole. So that makes a big difference if you have a kid that cannot swallow pills. What's nice about these non-stimulants is that they give 24/7 coverage of symptoms. So, you know, once the medicine's effective, once they've been on it for a few weeks, it's giving them coverage all the time, versus a stimulant is only giving them symptom coverage while it's in their system, which is for a finite period of time. There's a lower risk of certain side effects with these non-stimulants compared to stimulants, such as appetite suppression, interference with sleep, tachycardia, hypertension. Not that it can't cause these side effects, but the risk is lower. And these can be good options for kids that have issues with substance abuse or dependence. Next. Okay, medication shortages. So this was like a question that was I asked that I address this. So this is really going to affect any stimulant, methylphenidates, amphetamines. The stimulant that's most affected changes constantly. I feel like this is something where, as psychiatrists and I'm sure primary care providers, we're just like chasing our tail all the time with figuring out which one's in shortage and which one's not. It also can differ depending on where you live and where you practice, which medications are in shortage. Fluctuates with the time of year, so it tends to be worse when school's starting, when they're in midterms and finals, and then summer tends to be not as bad. So brand name medications are less likely to be in shortage compared to generics. They're more expensive, unfortunately. Sometimes we can get coupons, sometimes not. Next. Don't forget, non-stimulants don't go into shortage. I should knock on wood when I say that, but I've never seen a non-stimulant go into shortage. So this is really just a stimulant issue. So, you know, non-stimulants can be used alone, but also they can be used in combo with a stimulant to reduce the need for the stimulant. And sometimes that gives us a little cushioning if families are having trouble finding stimulants. At least they have something on board. And I think the most important thing is whenever I prescribe stimulants to families, I'm really honest about what it's going to look like. I explain all of the regulations around prescribing and filling stimulants. I explain about shortages so that they're prepared for that and it's not catching them off guard. I explain that I can't transfer prescriptions from one pharmacy to another. So I like for parents to go into that with the knowledge that it's not always going to be super easy for them. All right, next. Okay, so how to support parents and caregivers in general who have kids with ADHD. I think the most important thing is listening to them, validating their concerns. When they feel like they're being heard, they're more likely to like be on board with changes that you recommend, lifestyle changes. It's super important that they have education on ADHD, symptoms, the prognosis, treatments, accommodations, etc. It's super important for them to know that they are their last line of defense for their child. You know, when no one else is advocating for their kid, they have to do it. And I always explain the limitations of medications. And sorry, it shouldn't say mediations, it should say medications. That medications don't make ADHD go away. A teacher once told me this line that I love and I use all the time: kids need skills and pills. So they really need to like have organizational skills to deal with the ADHD, not just take a medication and hope it goes away. And then there's a lot of great resources out there for parents. I like the Attitude magazine. It's online. It's very user friendly, and there's a ton of information on there. And I think that's it.
Awesome. Thank you, Dr. LaRose. And
Yes.
yeah, and Dr. LaRose, thank you so much for being present and presenting as well. And thank you to our Manning group over there. You know, it's so nice with these sessions about networking and like when the right people are on the right session, you know, as far as resources go. So appreciate your time and being here, everybody.
Thanks to everyone for, like Dr. Olivier said, we have our next session on June 10th in the chats, the link for CEUs if you need them, but we'll also send an email out with that link as well as the recommendations. So our next session is on June 10th, and we'll have a PhD that works in the school system presenting on IEPs, 504 plans, and school-related issues. So just to increase the knowledge of the providers that attend about those things. So thank you so much, everyone, for your time. We'll stay on for a few more minutes if there's questions. If not, look forward to see you in a month. Thank you.